I think, shall we go
start,
ahead with the
okay.
class, Rakesh? Yeah. So welcome once again this postgraduate teaching program. It's a continuation of the program which we had yesterday. And we all know yesterday we had discussed about specimens in obstetrics and gynecology. The speaker and the chairperson is Dr. Aswath Kumar. So familiar, he was already introduced yesterday, but I would like to tell once again, I'm so glad to tell about him again. He's so passionate about this whole PG teaching as such, and this program yesterday was so well accepted. We were just going through the yesterday's YouTube uploaded video, and there are already about 400 plus viewers for that, for our yesterday's program. So today it will be on instruments and drugs in obstetrics and gynecology. We will be having a separate session for contraception by Dr. Aswath itself, maybe by end of this month. And we will be a separate flyer will be sent regarding that matter. Dr. Aswath, we all know he is a professor for OBG at Jubilee Mission Medical College. He is also a trained office surgeon and a lab surgeon. He was our past vice president of Fox in 2019. And today he will be discussing on drugs and instruments in obstetrics and gynecology. So I think we'll go ahead with the meeting. Over to you, Dr. Aswath.
I think welcome Aswath. I just tell one word that Aswath has taken pain in preparing that, maybe because and it will be available in the Zoom, YouTube link afterwards. So you can afterwards also see that and refresh it. But always after this, if you have any doubt, you can directly ask to the master teacher or the master of teachers, Aswath, who has been doing the postgraduate teaching for many years. He's a good friend of mine. Welcome, Aswath.
Thank you, Messi and Dr. Srilada. Thank you. Thank you both. And the whole COGS team for inviting me. I'm always, as Fesi, we were friends for a long time from medical college onwards. Fesi was my senior, and some bonding was there within us, and we were in Foxy together everywhere. So whenever Fesi or Dr. Srilada madam calls me for a program, I cannot say no. But we will start the program today. Yesterday, we got good response through the YouTube. Many of you are viewing through the YouTube, I know. But let us start without any delay. Now the topics remaining are drugs is there, instruments are there, contraception. These are things which I will be taking. I will try my best. I will not hurry through anything. I will try my best to complete whatever today. So anyway, one more session has been given to me. So rest will be covered in that session. So we will start with drugs today. So rather easy to take drugs. So whenever it's a drug, whenever you are asked, first thing, whenever you are asked, you will take one drug is given to you, or you are asked to take one drug, whichever you like. When you take it in your hand, they will ask you mechanism of action, indication, any contraindications, which are the other indications other than what you have told. So any side effects are there. These are the common things. And how do you give? Any special precautions is there? So these are the usual questions for any drug, not like a specimen where you can ask anything. Here, there is some restriction of asking. So number of questions asked from a drug will be more. So contraception is entirely a separate table. So we have covered drugs in obstetrics and gynecology. I have divided it into different sessions. First of all, before starting, I should thank 4 of my PGs who have helped me. Dr. Marin, who is exam going, final year PG, not the exam going, and Dr. Henna, Dr. Adulya, and Dr. Gobiga, who has helped to compile this presentation. Okay, we will start with the drugs in obstetrics and gynecology. Fesi, are you able to see? Srilada madam, are you able to see the screen?
Yes, we are seeing it properly. Yes.
Okay. So we start with supplements in pregnancy. So this is one of the commonest question which you can have, and everybody knows iron will be and this will be the picture what you will be getting. It will be given to you. So when you come to the iron as such, see, they will ask you common questions, where even if it's an anemia in pregnancy, also common question, first trimester, second trimester, third trimester. As you know, as in the first trimester, it is 0.8 milligram per day. Second trimester, it is 4 milligram. Third trimester is 6 milligram. and the level, different classification. I have taken the ICMR classification, where you say that they will ask you what is the severe anemia. Less than 4, they say very severe, and severe less than 7. That is what the basic guidelines. And WHO, according to WHO, anything below 11, you say it is anemia and deficiency anemia. So these are some basic questions asked. This is the commonness. So why you will say ferrous sulphate? Most of the government colleges, it's available free of cost. So most of the government medical colleges, this will be the specimen, is ferrous sulphate will be the specimen. The most common used oral preparation, you have a 200 milligram tablets with 60 milligram of elemental iron anhydrous. See, 180 milligram dose of iron deficiency anemia is 180 milligram of elemental iron per day. Also available as syrup, as you know. Anhydrous for form better. Advantage is cheap, bioavailability is there, good bioavailability is there. And then, so you have the gastric discomfort and poor complaints is 2 things which you can have. See, different types of iron preparations, they will ask you. See, you have the normal iron preparation, ferrous sulphate, ferrous gluconate, all these are the normal iron preparations that you get. So you can see the recommended dosages that are given to in an iron deficiency anemia, not in a prophylactic dose. So, and the novel iron preparations. So, ferric citrate, ferric maltose, carboxymaltose, liposomal iron, sucrosomial iron. So these are all things which are, and I have written the dosage and the number of iron prescribed and the elemental iron content of it. Okay. When you come to some questions on iron deficiency anemia, so they say, how do you diagnose iron deficiency anemia? See, I have taken only important points. See, 2 things. CBC, naturally, you will be doing the complete bound count and the hemoglobin level. Other 2 things which are important, what I say is that MCV and red cell distribution width. Okay. See, in an iron deficiency anemia, what happens? You have a low MCV and an elevated red cell distribution width. Why red cell distribution width is important is that when you take thalassemia, red cell distribution width is decreased in thalassemia. So in iron deficiency anemia, low MCV, anyway, you all know. So elevated red cell distribution width. So that is the importance. Other markers like serum they will ask you, doing a serum iron is important or not. Serum iron and TABC can be done, but it's a unreliable. Why unreliable? So serum iron has a diurnal variation, and it is affected by the dietary influence, as you all know. Indian diet and pregnancy itself increases the total iron binding capacity. That is why TABC was not so useful. What is ferritin? So the ferritin, to cut off, we say 30 micrograms per deciliter to diagnose below, right? So to diagnose or treat iron deficiency anemia in pregnancy. But these are the indications of doing ferritin. Ferritin, we don't do any in all the cases. So I have written all the indications prior to starting iron therapy, therapeutic doses in hemoglobinopathies. Okay. But whenever it's preferable, whenever you are doing a parenteral. So what I do is that whenever I'm planning to do a parenteral iron, give parenteral iron, I make sure it's an iron deficiency by doing the ferritin levels. So that is one thing. The other things are written, even an alternative etiology of microcytic hypovolemia, you think you have to do ferritin level. Anything else other than you are thinking, you have to do. Suboptimal response, you are giving oral iron and it is not responding, then you have to do a ferritin to know what is happening. Then in non-anemic women with increased risk of iron depletion, like you're asked, previous anemia, multiple pregnancy, teenage pregnancy, all these things we do a ferritin level. And after 8 weeks of therapeutic iron dose, when a non-anemic iron deficiency is treated. So you have to see, that means in patients without anemia, serum ferritin is less than 30 and you are treating. So you are treating based on ferritin. So naturally you have to do ferritin. So they will ask you, so even routinely you don't do, then which are the conditions which you do ferritin levels in your practical exam? These are things which I am not going into details. Just to see, we are under FOXI. So many times examiners who are see what is the FOXI guidelines is being a common question which is asked by many of the experts. See, we have to follow all the international recommendations are there, but we have to know the FOXI GCPR guidelines are there, which is available in the FOXI website or the FOXI app. You can download and see, get all the GCPR guidelines. So just download today itself FOXI app, click GCPR guidelines, whatever is available till now will appear on it, and you can see through that GCPR guidelines what FOXI has recommended. So FOXI has recommended, you can see 100 milligram of elemental iron twice daily, plus 500 micrograms of folic acid. Okay. After achieving a normalized hemoglobin, we can decrease it. We can decrease to 60 to 100 plus 500 micrograms in recommended for at least 6 months during pregnancy, and should be continued postpartum. I have written the WHO recommendations on all sides. And if somebody asks you the WHO recommendation, also I have written on this side. You can see here WHO recommendation. Okay. Here, another question which is asked is that there are two forms of iron, ferric and ferrous. Okay, you can know. So bivalent Fe2 plus and Fe3 plus. So in which condition, which are the elements which are, when you give drugs which are having Fe3 plus? Ferric iron. Ferric iron is in iron polymaltose complex and ferric ammonium citrate. These are the two things in which the rest are all bivalent or ferrous iron. So ferrous ascorb, ferrous fumarate, ferrous sulphate, ferrous globin, all these things are there. So I hope that you can take the screenshots whenever, and it's available in YouTube also. Certain other practical points which are asked for the exam. See, no use of giving so much iron tablet and see absorption of oral iron increases with increasing the doses of oral iron up to 160. Then no use. Then no use of increasing the. Then when will you give? These are all practical points. Even if you are not writing for the exam, going back, you have prescribe him iron every day. So you have to tell that you have to take it in an empty stomach 1 hour before the meal or 1 hour after the meal. Preferably, what I say is that this is my common thing. Drink lot of vitamin C rich fluids. So what do you expect? This I will give you a better chart. 1 gram is expected in the end of 2 weeks, and 2 grams is expected, and rice is expected. For which I will give you a better chart. I will show you. See, when you come to parenteral iron, so this is two type of parenteral iron you have. One, you have the iron sucrose, and the other is FCM, Ferric Carboxymaltose injections. Okay. So parenteral iron, see, iron sucrose, what is the dose usually? So you cannot give more than, the problem of iron sucrose is you cannot give more than 200. So you can see here, 200 is the cutoff. So how do you give? You give it in normal saline. That is very important. All parenteral iron is given in normal saline. As examiner because examiners ask this because there are situations by, we had a case when a house surgeon by mistake, iron NS solution was not available. So he was added to parenteral iron, only was given, dosage was calculated, given to him. So what he did, he took dextrose drip and put it inside and gave. Severe thrombophlebitis. Almost we thought the hand will go. That much thrombophlebitis was there in that hand, and it was a difficult time because it was our mistake. So to deal with that patient was a very difficult time. So you have to small points. They will, in the practical exam, they ask, you put it in, they will say that, oh, you put it in 5% dextrose and give, like that. They will ask how many 5% dextrose. Then immediately you should say, no, madam, it will be normal saline that we will. 3 days per week, maximum 600 can be given. But on the other thing, Ferric Carboxymaltose, but in the first trimester it is not given, but second, third trimester it is approved now. So up to maximum up to 1000, or other way you can calculate is at 20 milligram per kilogram, and it should be given over 15 minutes. They will ask you small points which I am telling, that is what is asked for the exam. And how do you Gansoni formula? What do you mean? See, these are all useless questions. At least you know how it is calculated. Okay, what is that formula called and all? I don't ask such questions. This is what response to iron therapy. Okay, you can see how it responds to iron therapy. 12 to 24 hours, decrease irritability and increase appetite. That is the first clinical symptom. They will ask you, how do you know the response? Please, these are the which we are going to get from my class. 36 to 48 hours, initial bone marrow, that is erythroid hyperplasia. Reticulocytosis by 72 hours and peak by 5 to 7 days. But hemoglobin to increase, it takes time. So then only the changes, like a depleted stores increases after some time only. This is the response. So when will you give parenteral iron? That is what we told. Poor complaints to oral iron, intolerance to oral iron, and when there is history of malabsorption, we give parenteral iron. These are the indications and these are the contraindications. Contraindication, nothing. Any gestational period less than 12 weeks, you don't give parenteral iron. It's not proved. See, there is chance for teratogenicity. That is what they have told. And there any history of anaphylaxis to any type of iron, you don't give parenteral iron. And known state of iron overload is there, then also you don't give. And the indications we have written. When you say parenteral iron, see, what is this parenteral iron preparation? It is an iron core and a carbohydrate shell. So when that bound is strong, that is a stable iron. So it slowly releases the iron. So that is what you want to know, that the type 1, different types of the strength. Strength is so they will ask you what type of complex is. So type 1 complex is what is FCM. FCM is a type 1 complex. Type 2 is iron sucrose. So this is a chart which everybody take a picture of this chart. Everything is there. I am not explaining everything what we have told, timing of injection, every point is there. Please, if you take this chart out and read, everything is there. Whatever I have described as given in a one full chart. Ideal what it is, and almost that FCM comes to an ideal iron. That is the reason why. So this 15 minutes and all these things are important. Okay. Mode of administration, we told how to give and all these things. So iron sucrose, how do you give? Contraindications we discussed. And these are what some points about FCM. FCM is a parenteral iron, not associated with hypersensitivity, can be administered much higher dose. 15 minutes, minimum 15 minutes. Iron is released slowly, avoid toxicity and oxidative stress. That is by the importance of type 1 complex. Structure similar to ferritin, so deposited easily in reticulum system. Test dose not required, low immunity potential. These are different studies of iron. And this is what are the 3 advantages over iron sucrose. One, advantage number 1, higher dose can be given. Advantage number 2, fewer clinical visits. Then the third, near neutral pH and physiological osmolality is there. So an antigenicity and no test dose required. So these are some of the importance of iron. So I have taken some time on iron because it's very important. And these type of questions can be asked for the practical exam also. Now we will move it fast. See, now coming to folic acid. Folic acid capsule. Here the points of folic acid is how much is the recommended dose. Recommended dose is 400 micrograms per day. That is a recommended dose. So to low risk cases, that 400 microgram is enough. Moderate risk, that is maternal comorbidities are there, we increase it to 1 milligram. But whenever there is like open neural tube defect history, anticonvulsant she is taking, then here is case. Yesterday I told you we take 4 milligram per day. Yesterday when I talked about anencephaly, I told you mother has to take preconceptionally, previous of anencephaly or any neural tube defect is there, preconceptionally 4 milligram per. So when they ask you recommended dose, they want my 400 micrograms. What we give is actually 4 milligram. Okay, in the first trimester. So this is a national iron initiative for the pregnant woman. You can see how it is given. What is it? And it is clearly written 100 milligram element iron, 500 milligram folic acid given for 100 days after the first trimester from 14 to 16 weeks and repeated for 100 days postpartum. This is the initiative. Coming to the calcium. See, calcium recommended dose. So recommended dose is very important. Please remember this recommended dose, 1200 milligrams per day. Role of calcium. You should understand that calcium, why do we want to give calcium? Decrease the risk of hypertension. You know the theory behind you give higher dose can decrease the incidence of preeclampsia. Then low birth weight, decrease low birth weight and decrease the incidence of chronic hypertension in children. So these are the things which common things. See, there are many indications, but common things, at least you answer this 1, 2, 3. That is why minimum it's in. And they will ask you what is the commonest preparation available. You all know it is calcium carbonate. Most commonly used is calcium carbonate. Rest you can see the whatever is being written down, but only 3 points you remember in this. See, 1200, preeclampsia, calcium carbonate. Okay. Coming to very important topic, I have grouped it in such a way that it's easy for you. Induction of labor, okay, and PPH. Induction of labor, the first thing what you are the commonly used thing is that a cerviprime gel or a PGE2 gel. First point is it is kept intracervical. This Dinoprostone gel is kept intracervical. It's a pre-filled syringe, 0.5 milligram in 2.5 ml gel every 6 hours. That is what maximum 3 doses in 24 hours. We don't keep more than 3 doses. So maximum they ask you 3 doses in 24 hours. So whatever I circle, that are the important points to it. Caution is that oxytocin, this is where something important. See, oxytocin to be started 6 hours after the last dose. So this also is important. So you cannot start, they will ask you, okay, start the oxytocin, and it has to be stored in refrigerator at 2 to 8 degrees Celsius. We all know cervical ripening reduces everything and reduces the need of oxygen. All these things, oxytocin, all the other uses of Dinoprostone gel. Now the latest preparation, it will be asked for the exam, that is the pessary called Profess. It will be something like this. See, like a thread, it is being attached, and here where it is kept is the posterior fornix. So that is intracervical, this is intravaginal. Okay, here the dose is 10 milligram, releases 0.3 milligram per hour. We keep it for about 12 to 24 hours. So, but it's an excellent, it's a little costly, but it's excellent. And only problem is that there is a, you cannot have a fast delivery and go home. That is the only problem. So not like that you keep in the morning, you may have to take the delivery next day night. So many gynecologists don't prefer that, is the only reason. But, and another reason is that it's costly. So the advantages is that duration up to 12 to you, and or until the labor starts. So labor starts, you remove it. And the advantage, if there is a tachysystole, you just pull it out. It is a posterior fornix, is a thread, you pull it out, it's enough. And the most important is that you can start the oxytocin augmentation as soon as it is removed, you can start. So not like the other thing. So it has to maintain minus degree Celsius, -8 or something, -degrees. That cold chain is very important. You have to have a separate fridge. Yeah, otherwise the efficiency is very low. Coming to Mifepristone. Mifepristone as an inducing agent, not much used, but it is mainly used for MTP. Up to 600 you give in a first trimester. Emergency contraception, it's used 600 within 72 hours. Induction of labor also, if you are asked, 200 milligram per day for 2 consecutive days. You give in IUD and all, when it comes, we give. Endometriosis is given, you all know. Leiomyoma is also given. So yesterday we discussed about that. And so we have, and you have seen the contraindications also. So all these small things you have to remember. Small things you have to remember. Next. Now, see, these are the doses of, see, other uterotonics that are used. Oxytocin available. Only we will tell about all these things. You see only the only this part, comment part. Oxytocin should be avoided. Undiluted rapid IV infusion. Never give undiluted rapid injection. It can cause hypotension. Methergine, we all know you don't give it in hypertensive patients. Prostaglandins and Misoprostol, the same prostaglandins you can have, it's a prostaglandin PG. So that is why it should be avoided in asthmatic patients, and relative contraindication in renal, cardiac, and hepatic. Diarrhea, fever, and tachycardia common. Is on all prostaglandins. This is a common thing. Even PG, even also when you keep this is common. This diarrhea, fever, and tachycardia. You should know that these are the common. So points to remember in this: oxytocin, hypotension if you give it IV. Methergine, avoid in hypertension, can cause hypertension. Prostaglandins, please avoid in asthmatic patients, and it can cause diarrhea, fever, and tachycardia. Now coming to one by one, oxytocin. See, oxytocin infusion, 5 units in 500 ml, okay, or 10 units in 1000 ml RL. Then this is the 2 type of protocols are there. Low dose, where we start with the 0.5. So always oxytocin, you should have a infusion pump. Ideally, infusion pump. Ideally, you should have an infusion pump. Okay, I still remember, you are thinking of now. I still remember when I was doing my MBBS house surgency. in Thrissur Medical College under Dr. Paili sir. At that time, infusion pump was there, 1996. As a student, infusion pump was, we used to give oxytocin in infusion pump. I don't know how many of your hospitals are giving oxytocin in infusion pump. Okay, so that is the importance. Many times patients don't deliver because we are not administering adequate dose and we are not monitoring properly. Okay, it has to be also stored. Cold chain has to be maintained. So when you are asked, this cold chain maintaining has to be the important point. Understood? So this has also the cold chain maintaining. I told you, Profess, cold chain has to be maintained. Oxytocin, cold chain has to be maintained. So all these things has to be small things. It has to be understood. Then active management of third stage of labor. You all know we give 10 units IM, 5 units in 5 ml normal saline over 5 seconds you can push, and you can put 10 units in. These are the things which we do now. Previously we used to give Methergine, nowadays we don't give. Side effects I told you, hyponatremia, sudden hypotension if you give it IV, and neonatal hyperbilirubinemia. Monitoring has to be there. Uterine contraction 3 to 4 contraction. And these are all things which you know. You have to monitor the uterine contraction, and CTG monitoring should be there when you are giving oxytocin. Coming to Methergine. Okay, you can see the Methergine, a very useful drug. Third stage to preventing PPH. See, you know that you can give, how do you give Methergine can be given in IV, IM, or what different ways it can be given. Onset of action in IV, it gives 95 seconds. See, whenever it is given IM, it is only 7 minutes. It takes time. So don't expect when you are doing cesarean, give Methergine. The anesthetist will not give it IV most of the time. They are afraid. So they will give it as IM. So you just have to wait for a few minutes. Not that, oh, uterus is not contracted, then give prostodine. Then so you have to be patient. If it is bleeding, then immediately you may start also prostodine also. So it is given after the delivery of the placenta, actually, ideally. But if you are giving it before, it may. But the problem is that as the lower segment also contracts together, it may lead to retention placenta. That is why it is given after the delivery of the placenta. So how it is given? Maximum 5 doses can be given. That is another important point. Maximum 5 doses. Okay, they will ask you after 15 minutes you repeat. Then 4th hourly, after maximum of 5 doses can be given. Hypertension, see everything, whatever it's there. Contraindication is there. DVT, asthma, hypertension, and cardiac disease. Okay. Prostodine, which I told you. PGF2 alpha. See here, it's a 200 microgram IM. Here it should not be given IV. It can be given IM. 8 doses, maximum of 8 doses. Here the maximum of 5 doses. So all these points you note down. Whatever I am circling, please note down. Maximum of 8 doses in 15 to 90 minutes interval. Okay, so you can be given intramyometril also. It can increase the pulmonary vascular resistance. That is the problem because it is contraindicated. Pulmonary, a patient with pulmonary artery hypertension and asthma don't give Carboprost or prostodine or PGF2 alpha. Coming to our one of my favorite drugs, Misoprostol. The classical uses when I see every drug is like this. It has been prepared very well. I can tell you. See this, if you learn this much only will be asked for the exam. Drugs, it is very straightforward question. They will ask you Misoprostol, what are the uses? So you say that it is used in medical abortion, 200 micrograms, repeated 12th hourly. Induction of labor, 25 micrograms, actually 25, oral or vaginally you can give 4th hourly or 6th hourly. Okay. Then cervical ripening of uterine procedures, that is like intrauterine, sorry, not uterine, intrauterine, like hysteroscopy, D and C, D and E. So all these things, it is given to soften the cervix so that you can introduce. Atonic PPH, you keep 600 to 1000. Maybe the efficiency and all is questionable, but we all keep it to something is better than nothing. So we keep, it is a very safe at that time. The same thing, nausea, vomiting, diarrhea, fever, and all these things. Uterine tachystostoly and meconium aspiration. This is a very nice chart. prepared by the Safe Motherhood Committee of Oxy. So all of you take the picture of it. You get it in the net also. You type Safe Motherhood Committee in the Google, you will get it. PPH chart, you will get this chart, and you can download it and keep it for an exam. And not only for the exam, you keep it in your labor room. It's very useful. Everything is written. Whatever we have told is written in a nice way. Number of doses, dose, everything is written. So this is the final word. What is it? You can go through it, how to manage a PPH. Another drug which has come into management of PPH is tranexamic acid in a big way. So what is tranexamic acid? So they will ask, what is the mechanism of action? Antifibrinolytic, and it's a clot stabilizer. This is a 2 box. So what is happening? I have written clearly showing here, inhibits the conversion of plasminogen to plasmin and prevents breakdown of clot. So this is what, so you prevent it, breakdown of clot. Another way it is that increases the collagen synthesis, which preserves the fibrin matrix, okay, and increases the tensile strength of the clot. These are the 2 ways which it acts. Okay, if you are asked the mechanism of action, and very famous, will ask you about the woman trial. Please, effect of early tranexamic acid on mortality, hysterectomy, and other comorbidities in women with PPH. That is a woman trial. Women with diagnosed PPH enrolled from 193 hospitals in 21 countries. Significant decrease in death due to bleeding. Hysterectomy rates did not change actually. Death from all causes did not change. No increase in adverse outcomes with, but significant decrease in death due to bleeding was there. Okay. PPH, how much you will give? That also you should know. 1 gram within 3 hours of delivery. If it continues, you can give the second dose. But 24 hours, the maximum that you can give should not exceed 2 grams. Okay. Otherwise risk of cortical necrosis and seizures are there. Okay. Other uses is to prevent and reduce blood loss in abnormal uterine bleeding. You can see here, heavy menstrual. The other uses we do and we give during surgery. Everybody here would have heard, PGs would have said that your consultant telling, hey, give one ampule, 500 tranexamic acid kodutho, kodutille. Idoru syringe chodiyana. Bleeding undengilum illengilum we feel safe by giving tranexamic acid. We feel, but be careful, don't give it overdose. Today you will understand that it will be when the dosage and adjustment and all these things are written. Coming to another important topic, antihypertensives. Labetalol. Okay. Labetalol, they will ask you, what is the mechanism of action? Same. Alpha, beta blocker. Both alpha and beta blocker. First line drug. Another question. Like first line drug in preterm labor is Nifedipine. First line like in PIH is Labetalol. Okay. It's a rapid onset of action. 1 to 2 minutes the action starts. Normal gestational hypertension, what you give is 100 to 200. We start with 100 milligram BD, then we will increase to 200, then 200 TID, like that. Maximum dose in a day that can be given is 1200. I have heard so many examiners asking. Hypertension emergency, you know, 20, 40, 80, then every 20 minutes, like 20, like that, you increase. So maximum here you can give is 220, but in some books it is written, it can give up to 300. So last time when I was an examiner in Bombay, student told actually 220, examiner wanted 300. So how much more you can give, how much more it was like. So if the examiner is insisting on asking, you can say 220 is a recommended higher dose. It can be, studies have proved that you can give up to 300. That's it, finish. Side effects, you can have some fetal effects, that like fetal bradycardia and IUGR, if you give in a long-term basis, not in a short-term basis. Contraindications are there for Labetalol. It's not a completely safe drug. Reactive airway disease, bradycardia, heart block, pulmonary edema, these are the things. Alpha methyl dopa, not available very easily nowadays. In my hospital, it is not there. I don't know about your hospitals, but the old cover of alpha methyl dopa may be lying on the kit of the drugs in your kit. That may be the reason it will be also asked. So if you may not, now the PGs, none of the PGs would have seen using alpha methyl dopa how it is. When our postgraduate days, still 3-4 years back, it was the main drug we were used to give. So safety is excellent. That is why it's very safe. So we used to give for all the patients. Centrally acting alpha-adrenergic agonist. That is what the point you should remember. Centrally acting alpha-adrenergic agonist. So here coming to the dosage. See, 250 to 500, 6 hourly orally, maximum here 2 grams. It is used in chronic hypertension and moderate gestational hypertension. So it was very safe. 140/90, 140, that is 140/95, and all these things we used to be very happy giving methyl dopa because it's very. Another drug which were in our before labetalol was there, Nifedipine was the drug of choice. And many patients had sublingual. I still remember in my postgraduate days, we used to make hole in the capsule and press it sublingually. Sudden BP will come down, and we were very happy that the BP has come down. Many times we had to resuscitate the patient. Patient had gone in for hypotension. So sublingual has stopped. So that is what, do not use sublingual, even if it is it can cause an exaggerated BP fall. So it's a calcium channel blocker as well as a smooth muscle relaxant. Okay, metabolism is excretion kidney. You can have, it can side effects, hypotension, tachycardia, headache, contraindication, so contraindication heart failure and reduce ejection fraction. Whenever that's the same as heart failure. Second line antihypertensive, 10 to 20 milligram. What you give is that 4th hourly or 8th hourly, maximum 120 milligram per day. Rapid onset of action. You understood? 5 to 10 minutes, you will get the action. This magnesium nifedipine can be used also as a tocolytic. That is a first line drug. So I will come to it, tocolytics, nifedipine. We all know that nifedipine is a first line drug. The complications and all sides same. But only thing what you have to know is that you have to start 30 milligram stat followed by 20 milligram 8th hourly. This is what how you give nifedipine. So it is about, you can give it to about 48 to 72 hours. You can give it up to 48 to 72 hours. You can give it up to 48 to 72 hours. 1 second, I will just 1 minute I can. Okay, back. So 30 milligram oral followed by 20 milligram 48 to 72 hours. So you have another is an Indomethacin. So Indomethacin is also a very good drug. Anybody has not used. So it is, what is this? It is a prostaglandin synthase inhibitor. So it's a non-specific cyclooxygenase inhibitor. Understood? So what it is, it's a, what you have to do is that 50 milligram orally, they will ask you about Indomethacin. Even if it is not kept, when Nifedipine and methyl dopa and all these things are asked, they will definitely ask. When it's a preterm labor, they will ask you about Nifedipine, they will ask you. So Nifedipine 50 milligram orally stat followed by 25 milligram 4th hourly for 48 hours. Most of the one dictum is that you give up to 48 hours or 72 hours is enough for preterm labor. No use of continuing the drugs. Not like you continue Isoxsuprine for next 1 week or nothing like that. There is nothing. So you have to maximum. No use of even the studies say that 2 tocolytics together, that is also no use. Okay. 50 milligram orally stat, that is what. Then caution is that more than 72 hours cause closure of the ductus arteriosus. That is the reason why you have to be careful. So beyond 32 weeks, increased risk of fetal renal function impairment and oligohydramnios is there. Even you know that Indomethacin is used in the treatment of polyhydramnios. So the principle is what is written here. So so it is contraindication, platelet dysfunction, bleeding disorder, gastric liver dysfunction, bronchial asthma. These are, so one drug in preterm labor which you have to remember is Indomethacin. This is one drug which we were using right left till its complications were more. That is why we started using Nifedipine as the first line drug. It is a, you all know, beta-2 adrenergic receptor agonist. Whenever Nifedipine feels ineffective, we give a second line drug. 40 milligram in 500 ml normal saline till the contraction ceases. Or important is that if the heart rate goes more than 120, you have to stop. Okay. Then after the contraction ceases, you can convert it into IM or oral doses. You have so many side effects of that. Pulmonary edema is one of the most dangerous side effects. And we had complications in twins and all. You give Duvadilan with or Isoxsuprine, very careful. Many of the hospitals still now are using Isoxsuprine. I am not telling in cases I am also using. In cases where it is not effective with Nifedipine, we are using. So these are the contraindications. Other beta mimetics which were used previously was Ritrodrin. Terbutaline is another thing, 0.25 milligrams subcutaneously, especially in tachysystole. When the patient is having contraction, you give terbutaline. Another word that terbutaline is used before doing external cephalic version. So you have to use this before external cephalic version is another thing where we are using terbutaline. Okay. So all please remember, see which are the other uses. See why this class has been taken with a specific reason. You hear, I know that many of you are going for the exam. You hear these things, you know all these things, but when you hear from a teacher, you remember that point. Okay, sir has specifically told in tachysystole, in ECV it is used. So everybody, the examiner knows that Isoxsuprine Duvadilan is used in preterm labor. That is a basic undergraduate knowing. At your level, you have to know little more. Okay, that is what we expect from you. Then Atosiban, it's a wonder drug. I am using it because I am a part of Atosiban trial, which is being conducted in. It's an excellent drug, but it is very expensive. That is the reason if you give one full dose of Atosiban, it will go to 15,000-20,000 per patient. So it is not, it may come down as it's a FDA and all get proper approval, it may come down. So they will ask you, have you heard about that? So oxytocin receptor agonist, very few side effects. And the initial bolus dose, how do you give? They will say. So initial, this you have to by heart. Initial bolus dose of 6.75 milligram IV over 1 minute. Okay. Then the maintenance dose, 18.75 milligram per hour IV infusion for 3 hours, followed by you decrease again 6.25 per hour for the next 45 hours. That is 2 days. This is the 2 days the patient will be in the labor room. Okay, 2 days patient, then only you can shift the patient. That is only because you have to monitor the patient. Magnesium sulfate as a tocolytic. Okay. Magnesium sulfate reduces presynaptic release. I will say tocolytic as well as eclampsia together about magnesium sulfate. So all this you having all the mechanism of actions. It's kind of central and the peripheral. Magnesium sulfate. Therapeutic range, you all know 4 to 7. You have to look for, see, more than 10 entrance questions, 10 knee jerk goes, more than 12 respiratory failure. So all these things, contraindications are there. So renal failure, myocardial ischemia, all these things are the contraindications for magnesium sulfate. 2 use, one in eclampsia and another is as a tocolysis and neuroprophylaxis. Tocolysis and neuroprophylaxis, the dose is the same. This is taken from Williams. So you don't have to bother. It is 6 grams in 100 ml over 20 to 30 minutes. First you give, then you give 2 grams per hour, 20% solution up to 12 hours. So this is the tocolytic neuroprotection. So and neuroprotection, it's the same. Okay. Then you coming to eclampsia. If you go to the eclampsia and the neuroprotection, we give up to only 32 weeks. Okay. Coming to eclampsia as an anticonvulsant, EK, you can have suspend regime or that is IV regime, where loading dose of 4 grams IV in 100 ml normal saline or 15 to 20 minutes. Then what you do is that maintenance dose. Okay, maintenance dose of 1 to 2 milligram per hour. All these things you have to learn. It's a half is a maintenance. You remember, it's not exactly the same concentration, but you remember like that. It is that 4 grams per IV in 100 ml over 15 to 20 minutes you are given normal saline. That's also. And the maintenance dose of 1 to 2 grams per hour. This is what we follow. Pitchard's regime you can have where loading dose 4 gram, then IM both very painful. Then you put a loading dose, then you can have maintenance by IM. So all these things, dosage and all these things are given in the chart below. Please, all of you, see all these things. So I have marked the important things, but you have to learn. How do you monitor? I told you, respiratory rate 16 per birth, it should not go. Deep tendon works you may monitor. Yeah, and respiratory rate should be maintained above 16. Urine output should be at least 25. But you should understand one thing. Even when a patient comes, even having the no urine output also, they say that to prevent, if the patient is coming with eclampsia, you have to give the loading dose. Normal range, okay. Normal range of this antiprophylaxis and all these things are written. Antidote is calcium gluconate. So it is 10 ml of 10% solution, IV over 10 minutes is what is the dose. Coming to antenatal corticosteroids. See, this is betamethasone and dexamethasone. Okay. So coming to dexamethasone, this is a dexamethasone, betamethasone. First, we will tell you the dosages. We all know 12 milligram, 2 doses, 24 hours apart or 12 hours apart. Okay. Or dexamethasone, 6 milligram, 4 doses, 6 hourly or 12 hourly apart. So this is what. So one is 6 milligram, here it is 6 and here it is 12. But it is a double, it is given. That is why. Timing is, you all know, recommended between 24 to 34 weeks. For pregnant women who are at risk of delivering, within 7 days of delivery, if you deliver, that is the time when you give. Repeat dose, actually when you are asked in exam, not recommended, but a single rescue dose given to women, initial dose is given before 28 weeks or 7 days prior. That is the time when patient may deliver within 7 days. You can give a rescue. This is called the single rescue dose. In olden days, we used to give repeat doses. Antenatal, coming to antenatal corticosteroids, what are the advantages? So all it prevents. See, previously there were so many therapies. Phenobarbital was given, vitamin K. So many therapies were there. Now actually everything is managed by corticosteroids. So it's very simple. Increases lung maturity, prevents intraventricular hemorrhage, prevents necrotizing enterocolitis, systemic infection, mortality in the first 4 hours of life, everything. So that is the reason why antenatal corticosteroids is something very must in doing. Coming to another very important topic, that is ovulation inducing drugs, which an infertility specialist, many of you may specialize in infertility. So these things are used. Clomiphene citrate. Clomiphene citrate, you can see it's a, previously we used to use. Now the best inducing agent is letrozole. Letrozole, if you are asked, which is the best? Clomiphene citrate is, what is clomiphene citrate? You all know it's a selective estrogen receptor modulator. Okay. So how does it act? Occupies the estrogen receptor in the hypothalamus. It's unable to bind to the receptor. That is what, whereby FSH increases. So when the FSH increases, naturally folliculogenesis occurs. That is simple. Estrogenic effect on the ovulation and anti-estrogenic effect on the, that is one disadvantage of clomiphene. Many times when you give clomiphene, the endometrium may not grow. So if you give high dose of clomiphene for ovulation, finally you find endometrium does not grow. Then your exam, they will ask you, what will you do? Then you have to give either estradiol valerate or sildenafil citrate, like that. It can to improve the endometrium or endometrial blood supply. Okay. Dosage, you start with the 50, 150, maximum 150. 150, not 250, I don't recommend, but maximum is written by the books, but maximum 150. No ovulation. What do you mean by clomiphene resistance? They will ask you. No ovulation despite giving clomiphene for 6 months. This is another word which is asked for the exam. Another is, what is clomiphene failure? No pregnancy despite of ovulation. Giving for 6 months, both 6 months. So you should understand the word clomiphene resistance and clomiphene failure. All of you, please. These are the points which are asked for. These are the points which are asked. So incidence, clomiphene, incidence of ovulation is 75 to 80%. Pregnancy you get for 20 to 40% and multiple pregnancy in 5% cases. Uses, anovulatory infertility, PCOD, oocyte harvesting before IVF, and males you can use an oligostenospermia also. You use there, the dose of clomiphene is 25 milligram per day for 3 months. Contraindications are when there is an ovarian cyst, ovarian failure, hepatic dysfunction, some of the contracting clomiphene. The wonder drug which we all use nowadays is letrozole. There it's a serum, it's an aromatase inhibitor here. Yesterday I told you the use of letrozole in endometriosis. So you remember, coordinate it and remember. See here, it decreases the peripheral conversion of estrogen. What is the dose of letrozole? You start with 2.5, then 5, then even you can give up to 10 per day. So this is how they can even try it out, a single dose regimen. All this they tried. Advantage, see, this is the question which will be asked. Why you prefer letrozole? Monofollicular, so decrease OHSS. No anti-estrogenic effect on the endometrium. Better pregnancy rate. So no action on endometrium. Action on endometrium. So small things. See, you have to answer in a practical oral exam very fast actually. I don't know about in Kerala. When I go for examiner in Bombay, Gujarat, Delhi and all, in the afternoon, the candidate, all the examiners, 6 examiners are there. 6 examiners sits in a row and all the specimen, everything will be kept like this. And the student comes, a single student is being examined by all the examiners. But in Kerala, most of the places, you have tables where you will be going around and answering. But when it is in a same 6 examiners together are asking you questions, different questions, all these points have to be very important. So simple, if you answer this, what is the advantage of letrozole? Okay, you say that decrease incidence of OHSS because of monofollicular development and no effect on endometrium, full marks. You will go to the other thing. Leupride, you know it's a GnRH. Yesterday we learned a GnRH analog in case of endometriosis. So here the advantage is that when you give, it activates GnRH and cause naturally FSH and LH secretion causes. Uses especially in IVF cycles, prevent premature localization and synchronize follicular development. So controlled ovarian hyperstimulation. It's called the not the OHSS. Controlled ovarian. We want to have controlled ovarian hyperstimulation. And ovulation trigger can be also done with the leupride or GnRH. Okay. Male infertility, you can give it whenever there's a hypothalamic hypogonadotropic hypogonadism. Excellent drug. Uterine fibroids and endometriosis, that is what we and recurrence. Okay. Now, what are the different protocols? See, you see here clearly. See, there are 3 protocols. 3 protocols are there. The protocol, first protocol is what is called the ultra short protocol. Ultra short is, you can see, it starts from 2 to 5 days or 3 to 5 days, 3 to 6 days, you can say. Short protocol, you can see here, from 3rd to till you give HCG. See here, 3rd to till you give HCG. Long protocol means the previous cycle. See, you are starting from the 21st day of the previous cycle. You may overlap with many people give OC pill, and the last 3-4 days you overlap the GnRH and then you go forward. That is what is called. So you understood, everybody? I feel that everybody understood ultra short, short and long protocol. Long protocol, you start from the previous cycle. All these are complications which you can read. Hot flushes, and it's all GnRH. Wherever you give, yesterday I told about this complications. You can see all the complications. You can take the picture. Coming to HMG. HMG is a combination of FSH and LH in equal. So FSH giving for ovulation induction after the failure of letrozole or Clomiphene citrate. It's an order we give. Or FSH, people say that FSH and HMG has the same effect. Nothing much difference is there. And FSH also promote follicular mature ovulation. Adverse effect of this HMG or FSH is ovarian hyperstimulation syndrome and multiple pregnancy. That is common to almost all injectable ovulation inducing is FSH or HMG. You say that there are 2 complications. They will ask you, say OHSS and multiple pregnancy. Incidence of multiple pregnancy is more with injectable than oral. So that also another question they will ask. HMG given different ways. Step down. Initially, you give a high dose, then bringing it not step down. Then it's a low dose. It's a step up protocol. Step up. So see the step up protocol. Chronic low dose, you are giving a low dose, chronically low dose you are giving. These are different types of HMG protocols. Previously, we learned different types of protocols for GnRH, short, ultra short, and long protocol. Okay, these are all things you should remember. Cabergoline and bromocriptine. Cabergoline and bromocriptine, if you take bromocriptine, synthetic ergot derivative. Okay, mechanism of action, dopamine D2 agonist action. Hyperprolactinemia, whenever is there, you start with 2.5 to 10 milligram per day. Okay, so lactation suppression is the basic principle. It can be also used. So you two uses, hyperprolactinemia and lactation suppression. Side effects, nausea, vomiting, postal hypotension, behavior alterations, skin condition, libido reticularis, contraindications are there. This is the cabergoline. This is the bromocriptine. It's the same, almost the same. So same here, cabergoline is now more commonly used than bromocriptine. So we give cabergoline 0.25 milligram twice weekly or 0.5 to 2 milligram once weekly. Two type of dosage can be given. In ovarian, another use of cabergoline is, please, ovarian hyperstimulation. See, OHSS. See, it is not that you are not knowing. Whenever suddenly you are asked something, you have to answer immediately. That is another use is, I'm inhibit lactation, hyperprolactinemia, then you should come that OHSS in your mind. 0.5 milligram OD into 8 days. Suppression of lactation, you can have a stat dose immediate. So otherwise you can give a 0.5 milligram BD for 3 days. Advantages, safe in pregnancy, side effects similar to bromocriptine, but lesser side effects are there. Now we will go to the last part, some miscellaneous drugs. Anti-D. Anti-D, you all know, to prevent C. You can give 300 micrograms. Half-life is C. It's a IM injection. It's a polyclonal product of human plasma. Half-life is 24 days. You can give 300 micrograms, provides 12 weeks of protection against exposure to 30 ml of blood, bar 15 ml of fetal RBC. This is the correct protection in micro. So routine antenatal, how you can give 300 microgram routinely, non-sensitized woman at 28 weeks. When the blood type is unknown, fetal blood type is unknown, you can give, or known, you can give after 72 hours. This is the antenatal or the first trimester. You can have whichever cases. You give at a lower dose, many times it is not available at a lower dose, that is a problem. If you get it at a lower dose, that is enough, 50 to 100 micrograms. So which are the conditions? RH negative, RH positive husband, having threatened abortion, ectopic pregnancy, spontaneous miscarriage, MTP, surgery, all these things. Second and third trimester, as we told, at least 300 micrograms. At least you give around 28 after 28 to 30 weeks usually, because I told you it's a 12 weeks only the action may remain. Amniocentesis, intrauterine death, abruptio placenta, all these things, ECV, all these things which we told. So postpartum, we all know. That is what all of us know. Okay. So this is within 72 hours, or if you are not given with them, as early as possible. That's it. HPV vaccine, primary prevention, CS cervix and genital warts. Okay. 5 to 6. There are different types of HPV vaccines are there. 026. Nanovalent vaccine is also the bivalent, quadrivalent, nonavalent. So 9 to 13 years is the best. Otherwise, you can give it. So before the first intercourse or before the exposure to HPV virus, that is the importance of giving as early as possible. So these are the different types, and you can take a picture of it. Which are the things it can prevent and all these things. So the advantage of using the Cervarix is HPV. Cervarix is a bivalent. Quadrivalent and nanovalent advantage is that they will ask you, it can prevent genital warts also. That is the only thing. So the extra prevention, but when you are asked, protection for cervical cancer is the same with all. Some books say it is more with the bivalent vaccine. Some books say, but when you are asked, you say that protection against cervical cancer is an additional advantage it has against genital warts. So it can prevent. What are the other cancers it can prevent? That is another question they will ask you. Cervix, vulva, vagina, penis, anal canal, oropharynx are the other it can prevent. Coming to the last drug of the day, then we will go to the, we are the correct 1 hour I took for clindamycin and clotrimazole, vaginal suppositories. Okay. See, here it's a, you can see, this is a very common, is very commonly used. That is why bacterial vaginosis, clindamycin, they say most of the time it's a mixed infection in the vagina. That is why you use clindamycin plus clotrimazole. So how it is given, dosage and all these things are written here. This is something, colored kits are available. So most of the government hospitals, the government is giving this colored kits. It's very simple actually. A gray kit, a patient comes with a urethral or anorectal or cervical discharge, a gray kit is given. Azithromycin plus cefixime. Vaginitis is there, green kit is given. Genital ulcer is there, disease is there, non-herpetic kit, white kit is given. Herpetic, non-herpetic with allergic to penicillin, blue kit is given. You are giving red kit where it's isoclavir. Like that, inguinal bubo, PID, you can see PID, cefixime is given, and metronidazole is given, and doxycycline is given. All these things are there. So these are the different, you can take a picture of it. And if you ask the color, either color, you may not have to know all the color so well, but at least you should know there is a color coding system, a syndromic approach that is there. So this is about the drugs. I finished in correct time. Now, now we are going to the next part of the class. Okay. So next part of the class is we are going to instruments. Instruments. Okay. Okay. Just before instruments, I will have a glass of water and then we will start. Hello, can you hear me?
Yes, yes, Dr. Ashwath.
Yes,
we can hear you well.
Yeah. In between, madam, you can tell me that because I feel that.
Yeah.
Okay. So the drugs are completed drugs in time, madam. Okay. Hope that it isn't a little fast I was, but I hope that everybody, madam, you understood things like.
Of course, very crystal clear.
So that's it. So everything has been discussed, but I have not left anything. But little fast than yesterday because I have to complete the portions. That is why. Sure. Okay, without any delay, we are going for the next thing. Instruments. So the first instrument is very common. Every day, every patient. Okay, every post-operative patient has this instrument. That's a Folic catheter. You may be thinking that what to answer on this Folic catheter, but many things are there which you have to answer. So commonly, what are the size? They will ask you. You may not have, many of you may not have thought of it. So commonly used is 14, 16, 18. Then it's a very thick. It's 18 is very thick actually. So as it goes on, the thickness increases, not like the cannula, where as the number grows on, the thickness decreases. Okay. Number 8. It's the smallest word used for saline sonohysterosalpingography, SSG. So there we use a number 8 that is called the pediatric Folic catheter. Okay. There are two channels are there to inflation. The bulb we inflate with usually 5 to 10 ml of water. You can inflate up to 30 ml. It will not break, but some people use this Folic catheter as PPH. Even the Becquerel balloon, what is used in PPH, is a modification of Folic catheter only. And one to drain the urine, as you all know, it is in the steroid pack, gamma sterilized by how it is sterilized and kept. It's a ETO sterilized. Small points. Uses, if you see about the uses of Folic catheter, urinary retention, CBD after, that means any surgery like vaginal hysterectomy, when you do a PFR, when you do VVF repair, vaginoplasty, whenever you require to monitor the input-output chart. So you have a PIH or eclampsia, pre-eclampsia patient or eclampsia patient, you want to monitor, you put a Folic catheter. Saline infusion sonography, as a tamponade I told you, it can be used as we use mechanical induction. Putting extra amniotic saline also we use, and amnio infusion also we can use. Not much nowadays use, but you can use with this Folic catheter. We start with instruments in gynecology first. We have divided into gynecology and obstetrics. This is what is this? I am not asking anybody because of the lack of time that I know. This is a ring pessary. You should know that what are the types of pessaries you should know. There are two types of pessary. If you can have support pessary and space occupying pessary. So two things are vaginal can be one for support, one space occupying. It will block out, coming out. That means the uterus is coming out, is put a space or something like a ball into the vagina so that it doesn't come. Space occupying. Now, examine the patient. Before examining, you have to examine the patient. Insert by folding it. Like this, you fold it and keep it, push it high in the vagina. First, you have to push it to the posterior fornix, then and the pubic symphysis. These are the two in which you keep. Once fitted, ask the patient to stand and walk and pass urine, and then the patient can go. First degree, second degree prolapse, decubitus ulcer. When there is high risk for surgery, and most important is that prolapse in first trimester of pregnancy. After second trimester, uterus will automatically, as the uterus enlarges, the cervix will be pulled up. So don't need to worry. Complications are, most common complications at vaginal discharge and irritation. That is why you have to take it out, clean it, and keep it inside. If you leave it for a long time, it can cause erosion and even it can cause fistulas. We had difficult time taking a pessary from the bladder. A part of the pessary was inside the bladder. It has eroded the anterior wall. It is inside the bladder and there was fistula. This is what is called a Hodge pessary, preferably used in case of SUI, consists of silicone, aluminium, that rigid aluminium filling in it. Okay, it's more rigid than the. See, this is the best picture which I can get from the net. So please, all of you, take photo of this picture. Support pessaries, they have written ring pessary, Jehang pessary, and Hodge pessary. Space occupying pessaries, cube pessary, donut pessary, and gel horn pessary. So this has, and details are given below. So this picture, please remember this picture. You can, and it has clearly shown how each pessary is being fitted and which condition that pessary is used. Okay, so this is more than enough for your exam. This is how a pessary is being kept inside. This is a very common instrument which is asked for the exam, the Cusco speculum. So they use it's a instrument, Cusco speculum, bivalve, self-retaining. These are the two words you do. Bivalved, self-retaining speculum, opened by a screw, used to retract the anterior and posterior vaginal walls, mainly in the OPD. Posterior blade is longer than the anterior, as the posterior fornix is deeper. If you go and examine, slightly the posterior blade may be longer than the method of insertion. You know that separate, you go like this 90 degree, then you keep it like this and open and screw it. After that, unscrew it and close the blades completely. When you pull out, unscrew it and pull the blade completely. I still remember in an exam, they were asking to show how a pessary is by manually show how the pessary is. What happened was that screwing and all putting was he clearly showed with his, because patient was not there. Just then finished, he told. Then the examiner asked, do you want to sending the patient with the speculum inside? Then you should know same thing, you and the opposite, you turn it and then take it out. This is what. So what are the uses of this casco speculum? Routine gynecology, that is a routine per speculum examination. Whenever you want to take a pap smear, IUCD insertion, doing an IUI, when taking endometrial biopsy and colposcopy. So many other things are there. I have written only given importance to only the common things. Understood? Routine pelvic PS examination, pap smear, IUD insertion, IUI, endometrial biopsy and colposcopy. So you can see what are the advantages. Stabilize the cervix, it's self-retaining, can be adjusted to the size of the vagina and gives good exposure. No assistant is required. That we all know all this. That is a word itself, self-retaining, involves all these things. It stabilizes vagina, cervix. What you cannot do, you cannot see, cannot visualize the anterior and posterior vaginal wall. When you take the speculum out, you can see, but it is usually not possible. Lax vaginal walls are there, it will come in between and you may not be able to view it. Okay, limited space, carry out, there are modifications are there. Okay, what is this? Sponge holding forceps. It is an atraumatic forceps. Sponge holding forceps is used to hold the sponge. That is agreed. So and paint, that is another common instrument what we use. Another thing what it can use as use in DNC in holding. See, whenever you are doing a dilatation and evacuation, not DNC, cervix will be very soft. So if you are using a valsalum or a tenaculum, there is high chance that cervix will tear off and starts bleeding. You may do a very good DNC and finally dilatation and evacuation, and finally you land up in a stage where what you have to do is that you have to go back. Yes. Aishwarya, please unmute. Thank you. To hold the sponge, to prepare the operating area with povidone, and that I told. Then to place the copper PPI UCD. I will tell you when I come to the contraception in the next class. I will tell you all these things about PPI UCD, how it is inserted. So it is like you can use the sponge holder, or it's just like a instrument similar to sponge holder with a slight bend is there, which is a PPI UCD inserter, if we name it. After instrumental deliveries for cervical inspection. So you hold you gradually hold one like this, inspection of the cervix going around the cervix. Very common, another instrument which is pap smear and a cytobrush. So most of the time it comes together because we want to see, we want to take an ectocervix as well as we want to take the endocervix. And this can be used for HPV testing, liquid-based cytology, all these things. This can be helpful with a brush from the cervix you can take. So you rotate 360 degree, then you paste it onto a slide and put it in the 95% ethyl alcohol and send it to the pathology, where they will be doing a technique. There is nothing called papricolon stain, please. There is a papricolon is a staining technique. So don't tell in the exam you put papricolon stain over it. Papricolon stain, it's a staining technique is used. By mistake, I have written papricolon stain. It is wrong. Papricolon staining technique. Papricolon staining technique is used. So it's a broad. So that is why when you send so many pap smears, it's not an easy method. You go to pathology department tomorrow itself. If you are not writing the exam, you are a third year or second year resident. You go to a pathology department and see what is it. So cytobrush. See, pap smear, you take it 360 degree. Cytobrush, what you do is that this is a brush, like you rotate like this 180 degree, then rotate back. Rotate 180 degree, then rotate back, and then paste it over the slide. So this is how it is being spread over the slide. There is something called liquid-based cytology. I will show you liquid-based PAP. All these things can be used as a cytobrush. The advantage of liquid-based cytology is that, so this unsatisfactory smear becomes less. So see the conventional PAP and see the cells in a liquid-based PAP. So what are the advantages? They will ask you using a liquid-based cytology. Reduces the debris and inflammatory cells. 80 to 90% cervical cells are transferred. Reduces unsaturated samples in 70 to 90% of the cases. Only a part of the sample can be used and the remaining can be stored for other purposes like HPV testing. So these are the advantages important. So this is how it is taken. So a brush, you put it into a rinse it, take it, centrifuge it, then spread it, you will get like this. So the advantage, please remember all these advantages. Reduces the debris, reduces the incidence of unsaturated smears. You get almost 80 to 90% of the cervical cells you can see, and some part can be even other tests like repeated or other tests like HPV testing can be used. So this is the difference. Okay, always you should know there are coilocytes. Perinuclear halo is a classical perinuclear halo. Perinuclear halo is a classical feature of the coilocytes. Perinuclear halo. So halo around the nucleus. That is what is the, depending upon that, it is very easily. So you can see here how the grading occur. So you can have different types of grading system. It is taken from the your pathology text only. This photo from the pathology text only. Here I have to tell you something. See, please all of you listen here. When ideally pap smear should be reported by Bethesda classification. Cytology by Bethesda classification, histology by CIA. So when you have a report, cytology, ideally you can have class 1, class 2, class 3, class 4, class 5, class 6, like class 5. It's all based on this. Normal is class 1. Class 2 is what is ASCUS, SH and LSIL. HSIL is class 3 and class 3, HSIL, it is C. Class 3, class 4 and class 3 and class 4, but depends upon CIN2, CIN3 and carcinoma in situ here. See, so this is a very important slide. You can see classically how you have differentiated and what the PAP classification is there, what you mean by class 1, class 2, class 3 and the difference is there. In this Bethesda classification, I have given the classification. You can see the findings. You can take it. It's a normal classification taken from the net. Due to lack of time, I'm not explaining. See, all these things which you know. That is the reason why I'm not explaining. This you have to know. See, this is a question which is asked in pap smear. How do you screening? You will say. So how do you screen? So screening starts around 21 years or 3 years of active sexual life. Okay, within 3 years of active sexual life. Every 3 years from 21 to 29 years. Okay. If it is then you classify it's a non-high risk or high risk. If it is more than 30 years, it's a patient is a high risk patient. Clinical examination, pap smear and HPV DNA has to be done. If it is negative, it goes back here. If it is normal, then every 3 years, only 3 years, pap smear is only needed. How long? You can do up to 65 to 70 years if no risk factors, and 10 years of negative screening that include at least 3 negative. So you can show. So this is how the whole thing is done. Okay, so this is the pattern in which a screening in India, FOXI guidelines for screening. What is the guidelines for HPV testing? See, when you do HPV testing, HPV, yeah, there is a protocol nowadays. You can screen not only by pap smear, you can screen by HPV also. So in exam, if they ask you HPV testing, anybody who was on HPV testing, see HPV negative or positive. HPV negative, return to the routine 5 that yearly screening protocol what we follow. But if HPV positive, okay, then this is how you can do a VIA, cytology or genotype screening. Like that, you can see positive, negative, all these things I have written, colposcopy, when to do colposcopic biopsy. The same way, there is another thing, looks very crowded, but it's very simple. Take the photocopy, take a screenshot of it, and you get it in net also if you type this. Co-testing. Co-testing, when you do three only, see, co-testing means you are doing HPV and pap smear together. There can be only 4 type of findings. What are the 4 types? Either HPV negative, cytology negative, both are negative. Return to that 5-yearly screening protocol. You don't have to bother at all. If HPV is negative, that cytology is positive. Then depending upon what it is, ascus HSIL, then you have to go for colposcopy biopsy. LSIL, then you go for repeat co-testing after 1 year. Then again it's HPV negative, cytology negative, routine. Otherwise, if here the same, HPV positive and cytology negative. So only 4 possibilities, either HPV negative, cytology negative, HPV negative, cytology positive, HPV positive, cytology negative. It's almost the same. So HPV is positive and cytology negative. That is when you go for genotyping of the HPV. See, so if it is 16 and 18, then we have to go for colposcopy and biopsy. HPV positive and the cytology positive, definitely you have to go for colposcopy and biopsy. See, please, nothing complicated is there. Co-testing, simple, you remember. HPV negative, both 5-year protocol screening. No need to do anything. Only screening, routine screening with pap smear is enough. If HPV is negative and only the pap smear is positive, then you depend upon the HSIL higher grade. Okay, you do colposcopy biopsy. If it is a lower grade, after 1 year you do a co-testing. Okay, that is, then we decide. HPV is positive and imagine the pap smear is negative. These 3 questions are asked for the exam. They will confuse you unnecessarily. So it is simple. You look for the genotype. If the 16 and 18 is there, then you go for colposcopy and biopsy. Otherwise, you don't have to go for the routine screening, co-testing after 1 year, and it's the same thing. So same protocol is being followed. So you remember these 2 testing, please. This is leave it. And this is another very easy for learning. I have taken it all and kept it for you. Is that take pictures of it. It's very easy. Ask us, how do you manage? LSIL, how do you manage? HSIL, how do you manage? AGUS, how do you manage? Okay, these are the things which are, see, I will tell you one, rest of the things you can read. The patient comes with, you imagine ASCUS. ASCUS is a report in a pap smear. So you can do an HPV testing, or you can do a cytology after 1 year. 2 ways it can be. HPV is negative, routine screening. That be what we do, 5-yearly screening is only needed. If HPV is positive, then go for colposcopic biopsy. Same way, repeat cytology and previously what you told. That's the same way you manage. So all these things looks complicated, but once you read and write down the points, it becomes very simple. Okay. I will tell you, Avsan, and finally I will give you a chart. It becomes very simple. Okay, that also you take. But ideal charts are this. This is how you treat it. That is how you treat procedures, and see all this. Whatever be the procedure, whatever you get, the most important thing is that what you are doing is that if you want to treat it, CIN1, you don't have too much to treat. So colposcopy and biopsy is the maximum which we take and follow up. But CIN2 and 3, you do this, it is the ablation where you have to destroy the transformation zone. You have to deal with the transformation zone, full transformation zone, whatever you do. So you have 2 types of methods. You have conservative methods, that is destructive methods, and excisional. You destroy the transformation zone. Destroy the transformation zone. How can you destroy? You can use laser, you can use cryo, you can use cautery. You destroy the transformation zone. Or you can excise. Excise means by cone biopsy. Cone, you can use a knife cone. You can use leap or LETs. LETs is a type of leap only. LEAP is loop electro-excision procedure. A type of electro-excision procedure when we remove only the transformation zone, when we call it as a LETs. So this is how the basic thing is there. So you can see details. If you want, you can contact me. I will tell you. This picture you take, whatever it is being done, whatever described, it has been made into a small chart. But the other chart is more important than this chart. So unless you understand that, just by hearting this, no use. If you understand that, this becomes very easy. You don't have to by heart this. You have your own idea to write exam. Now coming to all of you, coming to this, it's a PIPPL, endometrial sampling. So the PIPPL endometrial aspiration curette, PIPPL endometrial aspiration curette. So you all know that you aspirate the endometrium out. So the endometrium which is hanging down, the endometrium is sucked in, and they say that it has an accuracy equivalent to DNC. Fractional curette, the word has gone. If anybody asks what is fractional curette, you take separate samples for endocervix and the endometrium, so that you rule out endocervical carcinoma. That is the basic advantage of doing a. And inside you go 4 walls, you take separately. Previously 5 specimens were there, and all these things all useless. So nowadays that fractional curettage has gone. Okay. Now, how do you do and all these things we all know. Hold it doesn't need, even if many times you don't even have to hold the cervix. In a multiparous lady, it will go very easily inside. And the trauma to cervix, it can be done as an OPD procedure. All these are the common things. You can use a valsalem to hold the cervix, and then you can go inside, they release it back. Now, in your exam, another thing. Now there are only 2 terminologies: hyperplasia without atypia and atypical hyperplasia. All the other terminologies are gone. Okay, this hyperplasia, atypical hyperplasia, is otherwise called EIN, endometrial intraepithelial neoplasia. Like CIN, we get endometrial. So previously we used to have simple, complex. Each was divided into simple hyperplasia without atypia, with atypia, complex hyperplasia without atypia, with atypia, and all. Nowadays they don't have any value at all. Now we have, it has become very simple. Okay. So so these are the, say, atypical hyperplasia and EIN. What is it I have written? You can, so here, whenever there is atypical hyperplasia, if it is a family completed patient, treatment will be hysterectomy. But if it is not a family and she wants to conserve, then you can give high dose progesterone. Megestrol 160, or you have to give 200. Okay. So it is very difficult. Medroxyprogesterone, you get it in 25 and you have to take 8 to 10 tablets per day. It is not possible. So megestrol is and the best is that see, you have you can put a Mirena. So atypical hyperplasia in a young age, they will ask you. So nowadays many atypical hyperplasia comes like PCOD patients, is so many. So you have to be married infertile patients with atypical hyperplasia comes. So what we do is that you put Mirena inside. You can give megestrol. After 6 months with Mirena, we do the endometrial sampling. And once the endometrium comes to normal, take out the Mirena, induce or take the patient for IVF. That is what the management we say. So this is how do you follow up an endometrial hyperplasia for a premenopausal woman. Okay. And there is, you have to know that endometrium, another question which is asked is that, see, will you take in all patients this endometrial sampling? See, endometrial sampling less than 40 years or less than 45 years, we take. Above 45 years, we take for all patients coming with irregular bleeding. And wherever with patients having endometrial thickness more. But below 40 years, we take for only high risk cases, like patient is a long-standing PCOS case, diabetic, obese, anything related. In that case only there is indication for. In that patients, whenever you have an irregular bleeding with endometrial hyperplasia, if you are giving contraceptive pills or hormones and the cycle regularizes, that means that patient is normal. Okay, you don't have to bother too much. But in all other cases, more than 45 years, you have to take endometrial sampling. Now, this is how you can note it. This is how in a premenopausal woman it is done. Okay, how do you manage a case in which endometrial hyperplasia in a premenopausal woman? This is what is called a Alice forceps. Now we will go fast actually. Instrument with a fine teeth, wherever, whatever things in abdominal hysterectomy, hold the rectus sheath, you can hold the vaginal wall, vaginal cervical lips, you can hold. So about Alice forceps, I have written 2-3 things. There are so many uses which you all know. So wherever tissues we want to hold, thick tissues and suture and all these things, especially rectus sheath and vaginal walls and all, Alice is one of the most easiest instrument to be held. What is this? It's called the punch biopsy forceps. Please be careful. Don't mistake it, this punch biopsy forceps with other instruments. Please, many people see carefully. Whenever you get an instrument, open the instrument and see. Then you will not make a mistake. Okay. So you have to take. So then they will ask you, whenever a patient comes with a cervical growth or an ulcer, there is no role for pap smear. It directly you have to take a biopsy. And when you take a biopsy, from where you will take? Edge of the ulcer, if there is an ulcer. That is in vulval ulcer as well as in the cervical ulcer. Vulval ulcer, you cut with a knife. You take it, that vulval ulcer. Same thing, in a cervical ulcer, you punch at the edge. Otherwise, you punch in the center. What will happen is that you will get only necrotic tissue and there will be bleeding. Then they will ask you, oh, a cervical cancer, you have held and bleeding starts, what will you do? You can use Monsil solution, Monsil sulfuric metabisulfite solution, where you use it for all the cervical biopsies and all these things. Pack it. Then also bleeding, you can give tranexamic acid. Then also bleeding is going on. Then you may have to open up, do an internilear ligation. You can put, and even I have seen a case where landed up in hysterectomy. Before getting the report, we had to do earth-time cystectomy. When I was in PG days, in doing an oncology fellowship. So all these things are how you manage a bleeder on the cervix if you take a biopsy. This is what is called a ovum forceps. So ovum forceps, like a cup, it will be. Edge is like a cup, like this. It will cup. So you all know, and there is no lock. Ovum forceps, there will not be any lock. So because it's so open and close action should be there. You hold it, take it, hold it, take it. Like that it goes. So it's a DNA curettage products. That is the most important of an ovum forceps. It's a very, very important instrument for an ovum forceps. So like complication of every instrument putting inside the uterus, 3 complications are 1, 2, 3, immediately you should say perforation, bleeding, infection, finish. And injury to the surrounding structures. When you perforate, what are surrounding structures? Bowel, bladder, finish. So this is common for every instrument you put inside the uterus, even if it's an Haggard. And then came the Haggard's dilators. So these are Haggard's dilators. And you can see that calibration on both ends. That is the importance of Haggard's dilator from other dilators. Different diameters are available. So you at least you dilate up a weeks. We are seeing up to that week or 1 week more than. If it's 8 week, you are doing 10. You can dilate up to 10. So different types you can do wherever it's not only in the NC hysteroscopy to enter the hysteroscope. Many times in an office hysteroscope, you may do it without dilatation. Then in brachytherapy, drainage of pyometra, you can use cervical stenosis to increase uterine manipulation during laparoscopy. So many things are there. So Haggard's dilator is another thing which you commonly see. This is what is called the uterine sound. It's a Simpson's uterine sound. Whatever name is otherwise called hysterometer, also to measure the length of the uterus. So it has an angle, curved or an angle, acute angle it will be having. Okay. So it is to confirm the size and length of the uterus. Any procedure before that you do this. But when it is a soft uterus, try to avoid. Like if you are doing for a curettage for a diatatiform mold, we preferably say that don't put the sound inside. It may perforate. Till now it is not perforated. It may perforate. Then they ask you if you perforate, nothing to do. Actually, nothing to do. Perforate with a sound, nothing to do. You leave it. Patient has to be. Don't send the patient immediately. Patient has to be observed for bleeding. Most of the time there will not be. Even if you perforate with the dilator also, most of the time it will stop by after some time. So many times we have seen through the laparoscope a dilator and we wait for some time and it will stop by itself. Then missing IUC, before taking X-ray, you keep it and sound, and you should know when you keep it sound in the cavity and take, you will be able to know. Nowadays, ultrasound has come, it may not be necessary at all. When I told you yesterday to use sound is used to differentiate between a pedangulated polyp and an inversion. Complication naturally perforation. This is a myoma screw. Myoma screw is used, see, not only for myomectomy, that is important. See, myomectomy, when you are asked what are the use of myomectomy, you should say myomectomy, then manipulate the uterus. Okay, so then how do you use the myoma screw? Cirrhosis of the myoma is excised, then you put the turn the myoma screw inside and slowly pull it and cut the sides and take the myoma out. It is also used to deliver while you are doing non-descent vaginal hysterectomy. You put the myoma screw on the fundus and pull it and deliver the uterus. So these are the different things which you use. And in non-descent, you have multiple fibroids. You in between you put myoma screw, remove one fibroid, debulk it so that the uterus comes smaller and smaller. It will come and very easily you can do the hysterectomy. These are two similar instruments. This is a tenaculum, single blade, single like this, and this is a valsalum. So we have two things, tenaculum and valsalum. Valsalum is a broad edge. Okay. So same thing. What are the uses are almost the same. To hold the anterior lip of cervix while doing anterior colporrhaphy. When you are doing a examination, the maximum traction, prolapse, you want to know, pull the, for IUCD placement and removal. Whatever I remembered, all these things are there. Hysteroscopy, when you are putting a hysteroscope, doing an HSG. Contraindicated in pregnancy because it causes bleeding. When you're pregnant, I told you, you can use with a sponge holder rather than a tenaculum or valsalum. Then it's an anterior lip. Now you're calling posterior lip. You want to see the endocoel to differentiate between the endocoel and the rectocoel. You want to see the posterior 1/3 of the vaginal wall. Ruptured ectopic. Previously, we used to do colpocentesis. Aspirating. Colpotomy, posterior colpotomy, colpocentesis, colpotomy, 2 words. Colpocentesis for ectopic, colpotomy for pelvic abscess. Endocoel, I told, transvaginal not done nowadays, previously, colpotomy and extending the incision posteriorly in BH. So you keep it like this and then, so these are the advantages lifting the posterior lip. This is Cocker's forceps. Okay, Cocker's you all know, ARM you all know, but it's an excellent instrument. Or not only an abdominal hysterectomies and all, we clamp the edges. So it can be used as a clamp also. Cornua, best is that you clamp the cornua so that the uterus can be manipulated to the sides very easily. These are some uses which we use in our hospital. That is why ARM you all know. What is this? This is a hysterectomy clamp. You can have a curved clamp and you can have a straight clamp. It will not have that a cocker. It will not have a teeth like a cocker. It will be clamp and with a lock. So you can have, so that is the difference between a hysterectomy clamp and a cocker. So see, it is used to clamp pedicles in VH. Okay, VH, AH, whatever. So all the clamps you can say, they will ask you the 1, 2, 3 from above, VH 1, 2, 3 from above. It's even an undergraduate question. Then there is how to remove that. These clamps can be used to remove the ovaries. Many hospitals nowadays have Piley's clamp for removing the Piley's clamp. This is the Piley's clamp. Okay, and it will have a hook like this, so that it will help you to not to slip the knot. So this is what is a Piley's clamp to remove the ovaries. Remove the ovaries. Ovaries. Piley's clamp. I will be so happy to repeat these names because I am sir is a person. It's a godfather for me in the obstetrics. Where otherwise I would not have taken obstetrics at all. You ideally you see some teachers and you take your subject. So sir is one person which who taught me. That is the reason I got impressed in gynecology. Third year when I joined gynecology, third year when I the MBBS, I never liked it. Then gradually when I became final year, it was one of my top choices. So all these things are what about the hysterectomy clamps? This is what is called the Lane's tissue holding forceps. So tough tissue holding process. The tough tissues, when you want, you hold this with pull it. So this is what when you if you have observed assisted NDBH or you have done vaginal hysterectomies, you know that delivering the uterus, you hold it and pull it down. So so they may ask, what are the prerequisites for? In this case, we may ask you about NDBH. Non-descent vaginal hysterectomy. Up to 12 to 14 weeks, when there is no descent, you go. No adnexal pathology and the uterus mobile with no adhesions are there. This is where when you can go for People who are experts in your teachers, be proud of your many teachers who will be doing NDVH in 16 weeks, 18 weeks, previous year, and all these things. That is a different issue. I told you a common person. What are the indications given in the books? What is this? This is simple. It's a two cannulas we will see. Uses are the same. It's a Rubin's cannula. See, HSG used for HSG and to test tubal patency by laparoscopy chromotubation. Okay, you syringe and you inject. It's a rubber stopper to adjust the uterocervical length so that it will not perforate. They will ask you, what is the use of this stopper? So you fix it. There's a screw also here. It has not shown. So it fix it so that you first measure the length with a sound, then keep the length, then only you manipulate. Otherwise, it will perforate. It can be also used for manipulating the uterus. Okay, very important instruments in laparoscopy, this Rubin's cannula. Another to dye testing is what is called the Leach-Winkelson cannula. It's a straight instrument, so you cannot manipulate the uterus, but it is a tubal patency, chromotubation, and hysterosalpingo. Uses are the same. One extra use of Rubin's cannula is that it can be used in manipulating the uterus. Okay. This is last few pictures. This is an IVP. So IVP pictures nowadays, it is not common to take an IVP. Then also, whenever there is a broad ligament fibroid, whenever there is a cervical fibroid, whenever you are operating on a recurrent endometriosis, whenever there is ultrasound shows there is obstruction of the ureters, all these cases, to know the ureter, we used to do IVP. And IVP was a common test when I was all CS cervix cases. When I was a student, IVP was done. Nowadays, IVP is not a must. IVP is not a must. It is not done in, even if in your asked an exam in CS service, IVP is not a must. So what are the uses? So check the normal function of the kidney, normal function of kidney. Anatomical variations of the kidney, that is horseshoe kidney. Course of ureter, to detect and localize the ureteric obstruction. And staging, I told you, CS cervix. Previously, used to say that in IVP, hydronephrosis and idiureter means it's stage 3B. Okay. Assess the ureteric involvement, broad ligament myoma, pelvic abscess, severe endometriosis before surgery. All these cases we used to do IVP. This is HSG, hysterosalpingogram. Urographin dye. Urographin dye is injected using a Rubin's cannula. Okay. Rubin's cannula will show you use to the with a Rubin's cannula, it has been injected. Then the patient is positioned on an X-ray, at least 2 to 3 films are taken. First film initially will give the outline of uterus, and the second film will give the tubes and showing the spill. That is how. Over the intestine shows multiple biconcave shadows. That is why it looks like this. So it also detects uterine anomaly as well as the tubal block. Immediately we showed, yesterday we told that 105 degree, and you remember that 1 millimeter. I don't know, you are remembering that values. Hope that you see the other video once more and see that how do you differentiate between a septate uterus and a bicornate uterus. And you should know both the classifications. This is the ASRM classification and this is the ESHRE classification. So both the classification, if they ask ESHRE, you have to have ESHRE classification. And all the juniors who are going to write the theory exam next year, who are listening to this class, this thing is important for your theory exam. Okay. There are 2 tapes are there. Transvaginal tape. Okay. So TVT is there. TVTO is there. TOT or TVTO, where it goes through the obturator. So this is the original TVT procedure, where it was a retropubic. It used to come like this. Problem of this, this is result wise, TVT is better, they say, but bladder injury was more common with TVT. Bladder injury was more common with TVT. Okay. Then came TOT procedure. TOT procedure from you can do inside out or outside in. This is what is called the inside out. And I will show you another picture. This is what is called the outside in. Whatever it is, you go from the in or out, the effect, the results are the same. That is according to your convenience. And all of you should learn this. This doesn't require much skill. It's a very simple procedure. Do 2 to 3. You will be by 10 cases. You will be mastery in this. Only that positioning and the point which you mark and all these things are the most important. Now coming to my favorite, laparoscopy. So one of the few things I will show you in laparoscopy. What is this Veris needle? So Veris needle here, I can tell you, whenever you put a needle or a trocar, this is how, this is just to keep you flow and all these things, just to show you Veris needle length and all these things, just to, you can take a screenshot of it, nothing. See, you should know how do you enter. Normal cases 45 degree, overweight 45 to 90, when in obese, it has to be there in 90 degree. Otherwise, you will not reach through and the worst thing what a laparoscopic surgeon can end up is that not able to enter the abdomen, because when your whole trocar will be in the abdominal wall, you will not be able to. Then they ask you why you prefer to do it in the umbilicus, where all the layers of the rectus sheath joins, no rectus muscle is there. That is why the thinnest portion, that is why we put the Veris needle at the umbilicus. So these are all to avoid. Now I will tell you which are the tests to, that is another thing they will ask you. Palmer's test. What you do is that you put the Veris needle inside. This is how you do. Put the Veris needle inside, and then you put saline, and then you aspirate. That is how you do. This is something direct trocar entry. That is what is shown. This is Palmer's point. Palmer's point. I will tell you what is Palmer's point. Another point, it's a Palmer's point. So when you say, so other tests to find out, so Veris needle is a very common instrument that is kept. Okay. So to create pneumoperitoneum, that is what is the function of Veris needle. Different lengths are available. Test to know that Veris needle inside the peritoneal cavity. One is the Palmer's test, or the withdrawal test, push saline and withdraw. If it is inside the abdominal cavity, normal, nothing will come, only bubbles will come. Inside the intestine, fecal matter will come. Inside the blood vessel, blood will come. Inside the bladder, urine will come. Okay. Then pressure test. That means you connect to the pressure insufflator, the pressure will flow easily. The pressure will show negative pressure, it will show, and the air will be flowing, carbon dioxide will be flowing very easily. So that shows that there is flow, free flow is there, that is inside. Saline drop test, you would have seen epidural, they put a saline here. What I do, the drop of saline over and just lift it, abdominal wall, the saline will be sucked in. And moving, when it is inside the abdomen, it will be freely, the needle will be moving. These are the 4 tests that will be. When you are asked what is the umbilicus, and this is the pelvis, you imagine. So where is the Palmer's point? Palmer's point is here, below 2 centimeter below the subclavicular line, 2 centimeter below the subclavicular line, the midclavicular line, sorry, and 2 centimeter below, in the midclavicular line, 2 centimeter below the subcostal plane, 2 centimeter below subcostal plane in the midclavicular line. Plane in the midclavicular line. That is what is the Palmer's. Why do you prefer Palmer's point? Because it's a least adhesion. So when you are asked in the exam, they will ask you simple thing. If there are multiple scars on the abdomen, where will you put? So you can say that I will prefer to do it in a Palmer's point, where there is a least chance of adhesions. Okay. So what are the different ways? Intraumbilical, supraumbilical, epigastric, depending upon where to put the trocar. Okay, where to put the trocar means it's our choice. Depending upon the abdomen, depending upon the pathology, you can vary. Intraumbilical is the most easiest. That is what we could. We can have Veris, we can have direct trocar, optical trocar, Hessen's technique. Surgeons, what they do is that they open up the abdomen. See, open the umbilicus. If you see the surgeon doing, they will open up sheath, everything, and they will hold, and then only they will put. They are very afraid. Actually, for the gynecologists, we are more confident in laparoscopy. I don't know. We don't know. They say that we don't know about the injuries. That is why we are doing all these things. So actually, other things we are afraid. But putting a trocar, we are the least afraid people than the surgeons. Okay. So direction, I told you, insert direction and secondary trocars, I told you. And another way of entry is that you increase after putting the Veris, you increase the pressure to 25. So so that the abdominal wall goes away from the intestines. Okay, abdominal wall moves away from the intestine. That is what. So when you put the trocar, it will not injure. That is about so that is about one way of doing it. Okay, secondary trocars, one way of putting so after putting the Veris, then we have to put in the primary trocar. So primary trocar, when you put the primary trocar, you increase the pressure and then put. Once the procedure, they will ask you what is the pressure you should keep. 12 millimeters of Hg, you tell. That the pressure throughout the surgery. Initially, you can raise it up to 25 millimeters of Hg. So these are the different things. These are the trocars. I wanted to show you some pictures. Trocars. There are then optics are there. Two types of scopes are there. 0-degree scope, we get a panoramic view. 30-degree scopes, where we use is that we want to know the, you want to see one side. You want to go below. Then all these things, 30-degree scopes are used. These are different types of trocars, different types of instruments. This is one thing that can be harmonic scalpel. It's an ultrasound. Just at least understand that it's an ultrasound instrument. This is hysteroscopy instrument. This is what is called the Collins knife and the loop cautery. This is a loop cautery and this is a Collins knife. Loop cautery is used for what? Loop cautery is used to take polypectomy, myomectomy, are the loop cautery. Collins knife is a single like this it is. It is used septal resection. Septal resection. Okay. When you want to do resectoscope, it's a hysteroscope, bigger hysteroscope. When you want to do a resectoscope, these are the different types of. This is Collins knife. This is loop. Different types of instruments that are being used in hysteroscopy. Light source, I told you, camera, 3D, HD, 3D, we have gone. Insufflators, and that is a irrigation, suction irrigation pump. See, this pump is very important actually. So one complication which can happen is that embolism can happen. So even the air, that means pressure is important. So what pressure you keep inside, you should not go more than 100 milli. Intrauterine pressure should be kept below 100, and you have to measure the fluid. So that is why this is called the hystromat. Then so this will measure how many fluid goes inside and what pressure should be maintained, and all these things should be measured. So the fluid deficit should be always calculated. They will ask you, whenever the fluid deficit goes more than 800, you learn certain words. More than 800, you have to be warned. More than 1000, you stop the procedure. So long procedure, whenever the fluid deficit means fluid is going inside, and they can cause hyponatremia. So the commonest fluid used, see, for the normal procedure, normal saline. Normal saline cannot act in a unipolar. It can act only on a bipolar instrument. So nowadays, all bipolar cautery instruments are available with normal saline. Is the best. But if normal saline is not available and you want to use a monopolar, then the best is glycine. TURP syndrome, what is a glycine overload, can cause cerebral edema and complications. That is why glycine cannot be used a long time. So previously, but you have only a unipolar, then you have to use glycine with the resectoscope. This is a uterine manipulator. These are things which can be kept inside the uterus and manipulated the uterus during TLH and all. There is a Kalman-Ferrand manipulator, is the classical oldest manipulator that is being used for uterine manipulation. But nowadays we don't use the intrauterine manipulation. We move the uterus with a myema screw from above. Two ways of doing it. This is what you all know, fallope rings. So we are going little fast now, 10 minutes only more. So fallope rings, we all know, these are elastic rings which we use for tubal occlusion. So causes ischemia and necrosis of 2 centimeter portion of the isthmic part of the tube. So where you all know sterilization is done at the isthmic portion. Isthmic portion is the portion of the fallopian tube is where the sterilization is done. Device applicator, you put the device. Best method of tubal as it is effective, and recanalization, if required later, can be performed. Okay. This is the instrument. Okay, this is the instrument, lab sterilization set. In the coming to few instruments in obstetrics which are very easily, I can go very fast. See, this is the episiotomy scissors. What they will ask you, only simple question, what are the structures cut during episiotomy? And then they will ask you about perineal tear repair. What is first degree, second degree, third degree perineal tear at the complete perineal tear, and how do you repair? Okay, please, all of you, remember these two things. So the study, you know these things. Structures cut. Structures cut one point, and then you have the perineal tears. So in this, you learn episiotomy scissors, only these two things will be asked. This is what we all know, Doyne's retractor, which is used to retract the bladder during cesarean. Greenamitage forceps. This is not so traumatic. So that is why edges of the, especially edges of the uterine incision, that is where transverse lower segment incision, greenamitage forceps. Many hospitals, I don't think they have. You hold with Alice and suture it. So we have in our hospital, but I am not used to this greenamitage. It's broad, so I don't like to hold it with a broad instrument. So many people use it. Pilisar and all uses this greenamitage forceps for suturing the, holding the lower segment. Okay, it is less traumatic than, and it holds tissue firmly and helps in hemostasis also, the edges. That is why the role of greenamitage forceps. This is what you all know, Sims double blade speculum. You learned Casco speculum. Here, first used for BVF repair, used to retract anterior and posterior vaginal wall, broad and narrow blades for multiple. So Sims, you Sims position, Sims triad, all these things you learn. Biconcave with smooth edges. Disadvantage is that patient has to be to the edge of the table. That is it's simple points. These are, patient has to be to the edge of, simple point it is, and requires an assistant. See, these two things are very simple actually. And even you may need a anterior vaginal wall elevator. Okay, that I will show you in the next slide. So to evaluate all these things which we retain, placental bales member can complete, missed abortion, visualize the cervix, all the condition. Then all the things which we told with Casco speculum also, which can be done with the Sim speculum. Okay. This is what is the anterior vaginal wall. When you use a Sim speculum to visualize the anterior vaginal wall, you have to use a anterior vaginal wall retractor. This is a curette which has a sharp end and a blunt end. We use sharp end used for DNC and blunt end used for DNE. That is that because the uterus is very soft. So to make sure that the uterus is empty, first we use the sharp end, then use the blunt end to make sure that, otherwise to avoid perforation. This is SR cannula. SR cannula. It's an excellent instrument because for PPH prevention, the most of the hospitals in Kerala is having, because Samartharam sir is from Kerala. That is why it's an excellent to prevent atonic PPH. So you have a long cannula with a uterine portion and so big large holes. So the basic principle is that it sucks the uterus. See, you create a negative pressure and uterus will be like this. You keep it the suction on for some time till the bleeding stops. After some time in the suction, blood will not come and you stop it. Okay, and then later again you can keep it like that. You don't disconnect the suction, let the cannula be there till you, after some time the bleeding starts again, you can on the suction apparatus. When you remove it, full pressure should be gone. With your hand you separate the, and then you remove it. And you have, once you have kept it, you have to pack, like you do it for condom tamponade. Condom catheter you keep. This is what is called a Beckery balloon, and you have condom catheters that also can be kept. So it will be a infant feeding tube, and the condom will be kept over it and tied and etio-sterilized and kept in your labor room. So when you would have seen when atonic PPH, it is not settled with your method drugs, we put a condom catheter inside, and you will know that 300 ml of condom, how much it extends and presses on the uterus and stops bleeding. So the advantage of Beckery balloon over condom catheter is that here it is so collected blood can come out. That is the only advantage of Beckery balloon, and it is very costly. One Beckery balloon costs about 10,000 rupees. So what is the cost of the condom? You know. And coming to last, MR cannulas. MR cannulas, you know, MR syringe or MR cannula, which is used for abortion. So performed up to 12 weeks. Complications are same. Perforation, hemorrhage. It's a perforation is less than with MR syringe, and is an excellent for MTP. Babcock forceps, not only to hold the tubes during sterilization, bladder repair, any intestine you can hold, lymph glands in lymphadenectomy, bowel, bladder, ureters, everything. Excellent instrument. Babcock's for tissue forceps is one of the excellent instruments where you can use. So any soft tissue can be held with bag. It's very least traumatic. It's atraumatic. This is ovum forceps, which we had discussed. This is this, you know, that this is the this is forceps. I'm going fast, only 2 minutes more. So see, Forceps, they will ask you to identify the forceps. This is an outlet wriggly forceps, pelvic curve, cephalic curve, and all these things inside cephalic and the pelvic outside. All these things are which are asked, and they will ask you the indications. Indications they will ask. They will ask the complication. Then they will ask you how do you apply the forceps, and most important, they will ask you the prerequisites. Parts and prerequisites. All headings you remember. Parts, prerequisites, definitely. And we then ask you what are the advantage of three advent vacuum can be applied on a unrotated head and a little higher station, as well as higher station and not fully dilated cervix. That is the advantage of vacuum over forceps. But forceps has advantage. Premature head, it can be applied. You get more strength. No maternal effort is needed. That are all the simple things which I can remember fast. So how do you pull? You can take slide shots of it. How do you pull and left blade flush and the right blade? They will ask you. They will show, keep a mannequin and say that how do you apply the forceps and show. So you put the left blade, then you put the right blade, then you keep it like this, pull downward, backwards, and then upward, maintaining the flexion, and then at the end extension. So that is how. This is just a if somebody has it, I put this is the Killen forceps. Killen forceps. Killen for rotational forceps. You rotate and take. That is a long bladed with a lock Killen forceps. Will be there for the exam. This is the only time you see the Killen forceps on the examination table. So at least you should know the name. This is something you may not see it, but you are asked in the exam. Piper's forceps, curved long forceps, which is used to delivery of the head of a breech. That is what is a Piper's forceps. They may ask you when will you abandon the forceps delivery. So difficulty in application of blades. No progressive descent with moderate track. And the delivery, 3 pulls is a maximum pull that can use vacuum, and there is no combined putting vacuum then forceps. There is nothing like that. So whatever instrument you use, 3 pulls is the maximum that you can do. If it slips, then you take the patient for cesarean. This is called Scansoni's maneuver, which is used. It's a nothing. It's a rotation. Here, there are left and right blade. Here the blades are anterior and posterior. Then rotate and take it. So that is the difference between the Killen's forceps and the Wrigley's forceps. This is what is called Murray and Trainer's axis traction forceps. This is so you can have this. There's a pull like this. You can have an instrument like you can see here. Maybe there in your hospital you can be asked. Vacuum, same thing. Vacuum extractor. You will be asked indications, prerequisites, complications, and how do you use different types of vacuum cups and all these things. What do you use and contraindications of vacuum. See how to apply prerequisites, suction. That then caput and the cephalometoma differences, different types of advantages of forceps, vacuum over advantages over forceps. What are the disadvantages, contraindications? You can see prematurity and high station, CPD, fetal coagulopathy. That is all same. And then scalp, the procedures, any procedures are done on the scalp, then you should not use scalpel sampling and all. Then may start bleeding too much. Like all these things are. Then this is a kiwi vacuum cup. Okay, it is a disposable kiwi vacuum burr. You can increase, very nice instrument. Any PG, anybody can use it. This is even the sister can use it, actually speaking. So it is very simple actually. You don't have need any assistant. You can raise the pressure, but the pull is not as good as a slippage is more with the kiwi vacuum. But in normal cases, it will, if the maternal effort is not there, patient is in epidural and the patient is not straining, all these things, it will be very helpful. This I don't usually prefer to, but if it is there, Simpsons for all destructive operation instruments. If it is in your hospital, you learn. Otherwise, no need to learn. Nobody is going to ask nowadays. So only if there is a hydrocephalus to destroy baby. Nowadays, see, even aspirate and take the baby down. Nowadays, even we do cesarean for hydrocephalus babies. Even in cesarean delivery, you have to be very careful. Our neurosurgeon tells that if you want to survive the baby, don't decompress the head fast. You should put a needle slowly. You should decompress. Once bleeding starts, the sinuses inside bleeds, no use. There will be intracranial hemorrhage and patient baby is of no use. So if you are so you have to be very careful. Through the frontanelle, slowly insert a needle, decompress, and then collapse the head and take it out. So through the cesarean also, it is not easy. You have to be careful to take it out. This is the last. There is a different types of X-rays can be shown. Some hospitals, but previous X-rays may be there. Breech will be there. This is a normal X-ray of a baby. X-ray pelvimetry and all nowadays we don't do. Previously we used to do for breech, we used to do for multiple pregnancy, any complication, IUD, which this was what we used to do. So thank you all for a patient listening. I know that I have gone little fast, but I have covered everything. Srilata madam?
Yes, I am very much here. Yeah.
And I am almost, it's more than 2 hours now.
I know.
And
but it was absolutely exhaustive, and